Hi everyone, welcome once again. Today we are going to continue with the remaining recalls discussion. Okay, so question number 11. Mechanism of action of prostaglandin I2 is. The options are acid secretion and mucus production, reduce intraocular pressure, inhibiting platelet aggregation and in relaxing vascular vessels, maintains patency of ductus arteriosus during pregnancy. So here in the question, they are asking about the mechanism of action of prostaglandin I2. Prostaglandin I2 is prostacyclin. Okay, so here the correct answer is option C, that is inhibiting platelet aggregation and in relaxing vascular vessels. That is the prostaglandin I2 analogs mimic the effects of prostacyclin in endothelial cells. So what are these prostaglandins? They are lipid autocoids derived from arachidonic acid. They both sustain homeostatic functions and mediate pathogenic mechanisms. Okay, they have played an important role, or they have high importance in mediating the inflammatory response. Okay, and they are generated from arachidonate by the action of cyclooxygenase isoenzymes, and their biosynthesis is blocked by non-steroidal anti-inflammatory drugs, that is NSAIDs. That's the mechanism of action of NSAIDs is blocking the cyclooxygenase enzyme and thereby reducing the generation of these prostaglandins. So here you can see the different types of prostaglandin analogs and their examples. The prostaglandin E1 analogs are alprostadil, lubiprostone and misoprostol. And this prostaglandin F2 alpha analogs are bimatoprost, latinoprost, tavoloprost and travoprost. And the prostacyclin analogs include epoprostinol, iloprost and treprostinil. So let's discuss in detail about each prostaglandin analogs. So the first one, prostaglandin I2 or prostacyclin. So they are potent pulmonary vasodilators. Because of this property, they are mainly used for the treatment of pulmonary arterial hypertension. And their mechanism is by inhibition of platelet aggregation, relaxation of smooth muscle, and vasodilatation of the pulmonary arteries. This epoprostinol and treprostinol are administered as a continuous intravenous infusion, whereas this treprostinil is administered orally or via inhalation or subcutaneous infusion. And the next are PGF2 alpha analogs, mainly include this bimatoprost, latinoprost, tavoloprost and travoprost. They are mainly indicated for the treatment of open angle glaucoma. And there's one more feature of this bimatoprost is that it increases eyelash prominence, length and darkness, so that it is approved for the treatment of eyelash hypotrichosis. Okay, now let's see about prostaglandin E1 analogs. Okay, so the first one is alprostadil. It's naturally produced in tissues such as seminal vesicles and cavernous tissues in the placenta and in the ductus arteriosus of the fetus. It maintains the patency of ductus arteriosus during pregnancy, and another use of this alprostadil is for the treatment of erectile dysfunction. So in the options we have seen an option that the one that maintains the patency of ductus arteriosus during pregnancy. So the prostaglandin responsible for this function is alprostadil. Okay, so the next one is lubiprostone. It is indicated for the treatment of chronic idiopathic constipation, opioid-induced constipation, and irritable bowel syndrome with the constipation. And next one is misoprostol. Misoprostol is mainly used to protect the mucosal lining of the stomach during chronic NSAID treatment. Okay, also it has geocytoprotective effect. How it protects the gastrointestinal tract? By stimulating mucus and bicarbonate production. And off-label, it is used in obstetric settings for labor induction. And it has high potential to induce abortion, so it is contraindicated during pregnancy. Question number 12. Which of the following medications have the longest washout period? Options are fluoxetine, venlafaxine, paroxetine and duloxetine. So here the correct answer is option A, that is fluoxetine. So this fluoxetine is a selective serotonin reuptake inhibitor, that is SSRI. It is FDA approved to treat major depressive disorder, obsessive compulsive disorder, panic disorder and bulimia nervosa. The peculiarity of this fluoxetine is that it has the longest half-life among SSRIs. That is, the half-life is about 50 hours. And the half-life of its active metabolite. Active metabolite is S-norfloxacin. It's very long, averaging 10 days. So because of this reason, both SSRIs and monoaminoxidase inhibitors, that is MAO inhibitors, require a washout period of at least 2 weeks before the other type is administered. So the exception for this condition is fluoxetine. That is, fluoxetine should be discontinued at least 6 weeks before a MAO inhibitor is initiated. So the discontinuation symptoms are unlikely with fluoxetine. However, more vigilance is required when changing from this medicine. And this fluoxetine is an enzyme inhibitor. It inhibits the activity of CYP2D6 isoenzyme. So the next question, which of the following is most likely to cause tinnitus and hearing loss in high doses? So the options are ibuprofen, aspirin, indomethacin and mefenamic acid. So all these options are non-steroidal anti-inflammatory drugs. So among these options, the one which is most likely to cause tinnitus and hearing loss in high doses is option B, that is aspirin. So the tinnitus and hearing loss are symptoms of salicylate toxicity. So the salicylates are found in the over-the-counter medications including aspirin, bismuth salicylate, effervescent antacids, ointments, liniments and oil of wintergreen. The another name for this oil of wintergreen is methyl salicylate, and they are mainly commonly used for their analgesic, antipyretic, anti-inflammatory and antiplatelet properties. The complex problem or the major problem associated with the use of this salicylates is salicylate toxicity. They may develop with either acute or chronic exposure to salicylates. So these patients with salicylate toxicity may have involvement of multiple organ systems including particularly the CNS. Okay, it can include cerebral edema, coma, agitation, tinnitus and seizures. In the pulmonary system they may cause hyperventilation or tachypnea, acute lung injury and the gastrointestinal system nausea as well as vomiting. Children are particularly prone to salicylate intoxication. Ingestion of as little as 10 grams of aspirin can be fatal. There is no specific antidote for salicylate poisoning. So how we can manage salicylate toxicity? So first of all, assess the severity of toxicity based on signs and symptoms, serum salicylate concentration and acid-base status. Then correct fluid and electrolyte imbalance. A large volume of crystalloid is typically required for severe toxicity. Treat hypokalemia aggressively if present. Then administer supplemental glucose if there are any alterations in mental status, even if peripheral blood glucose is normal. Perform gastrointestinal decontamination with the help of activated charcoal, even beyond the typical 2-hour time frame. Then administer bicarbonate infusion to alkalinize urine. Why we have used bicarbonate here? Because salicylates are acidic in nature. Okay, so this bicarbonate infusion is used to alkalinize urine, thus increasing urinary salicylate excretion, and to alkalinize serum, thus trapping salicylate anions in the blood and preventing diffusion into the central nervous system. Then enhance elimination and correct metabolic acidosis with hemodialysis in patients with severe toxicity. So all these steps can be utilized for the management of salicylate toxicity. Question number 14. A 76-year-old man with uncontrolled hypertension is experiencing typical angina pain that is relieved with a rest and a sublingual nitroglycerin. He has a high blood pressure, that is 178/92 mmHg, and a low heart rate, that is 54 beats per minute, which is the most appropriate therapy for his angina at this time. So in this question, the patient has two conditions, that is high blood pressure, that is uncontrolled hypertension and angina. And his current blood pressure is 178/92 mmHg and he is having a low heart rate, that is 54 beats per minute. So which among the options will be most appropriate for his angina at this time? Okay, so the options are ranolazine, verapamil, metoprolol and amlodipine. Okay, so here the correct answer is option D, amlodipine. Okay, so now let's discuss why we have chosen amlodipine as a correct answer. So these are the drugs that are mainly used for the treatment of angina. So the first one is beta blockers, which includes propranolol, atenolol, bisoprolol and metoprolol. Then calcium channel blockers, among them dihydropyridines include amlodipine, nifedipine and felodipine, and non-dihydropyridines include diltiazem and verapamil. Then another option is nitrates, which includes nitroglycerin, isosorbate dinitrate and isosorbate mononitrate, and then sodium channel blocker. An example is ranolazine. Okay, and here you can see the drugs of choice or the class of drugs which can be used in case of concomitant diseases. Okay, if there are no other concomitant diseases, the options are long-acting nitrates, beta blockers, and calcium channel blockers. And in case of recent myocardial infarction, the options are long-acting nitrates and beta blockers. And in case of asthma and COPD, long-acting nitrates and calcium channel blockers are used. We are not using beta blockers because beta blockers are usually contraindicated in asthma or COPD because they may cause bronchoconstriction. And if in case of hypertension, okay, so in the question we have seen that the patient has got hypertension, that is uncontrolled hypertension and angina. So in such cases, we can use beta blockers and calcium channel blockers. So why we are not using beta blockers? Because in this particular condition, the patient has got low heart rate. So this beta blockers will further reduce the heart rate. Because of this reason, we have not chosen beta blockers. So the calcium channel blockers are the correct option. And in case of diabetes, we can choose long-acting nitrates and calcium channel blockers. And in case of chronic renal disease, long-acting nitrates and calcium channel blockers are the drugs of choices. Beta blockers are least effective drugs. Beta blockers should be avoided in patients with severe bradycardia. Bradycardia means low heart rate. However, they can be used in patients with diabetes, peripheral vascular disease, and chronic obstructive pulmonary disease as long as they are monitored closely. Verapamil slows atrioventricular contraction directly and decreases heart rate, contractility, blood pressure, and oxygen demand. Verapamil has greater negative inotropic effects than amlodipine, but it is a weaker vasodilator. Then what about amlodipine? It is an oral dihydropyridine. It has minimal effects on cardiac conduction and functions mainly as an arteriolar vasodilator. The vasodilatory effect of amlodipine is useful in the treatment of variant angina caused by spontaneous coronary spasm. Here in this case, amlodipine is the best choice because it will improve angina as well as help control blood pressure without further reducing the heart rate. So in the other options, we have seen the beta blockers. It will reduce the heart rate. And what about verapamil? Verapamil has also great action on the myocardium. It has greater negative inotropic effects compared to amlodipine. So because of these reasons, we have omitted the other options and chosen amlodipine as the best choice because it will not further reduce the heart rate. Then what about ranolazine? Ranolazine inhibits the late phase of sodium current, improving the oxygen supply and demand equation. It has anti-anginal as well as antiarrhythmic properties. It is most often used in patients who have failed other anti-anginal therapies. Okay, so question number 15. Digoxin is used to treat. The options are angina, atrial fibrillation, myocardial infarction, and torsade de pointes. So here the correct answer is option B, that is atrial fibrillation. So the cardiac glycosides are often called digitalis or digitalis glycosides because most of the drugs are obtained from digitalis plant or foxglove plant. So this digoxin is a cardioglycoside used in the treatment of congestive heart failure and for ventricular response rate control in chronic atrial fibrillation. It is a positive inotropic and a negative chronotropic drug, means it increases the force of heartbeat and decreases the heart rate. Okay, so the decrease in heart rate is particularly useful in cases of atrial fibrillation. So this atrial fibrillation is a condition characterized by fast and irregular heartbeat. So serum trough concentrations of 1 to 2 nanogram per ml are desirable for atrial fibrillation or flutter, whereas low concentrations of 0.5 to 0.8 nanogram per ml are targeted for systolic heart failure. And one more peculiarity of this digoxin is that it has got long half-life. The half-life is about 30 to 40 hours. It is eliminated intact by the kidney, requiring dose adjustment in renal dysfunction. And it has got a low therapeutic index, so that the dose should be individualized with regular monitoring of serum concentrations to avoid toxicity. So in this slide, we are going to discuss about the mechanism of action of digoxin. There are mainly three mechanisms. So the first one is regulation of cytosolic calcium concentration. It is by inhibiting the Na plus K plus ATPase enzyme. Digoxin reduces the ability of the myocyte to actively pump sodium from the cell. So this ultimately results in a small but physiologically important increase in the free calcium and thereby leading to increased cardiac contractility. So the next mechanism is by increasing the contractility of the cardiac muscle. So this digoxin increases the force of cardiac contraction, causing cardiac output to more closely resemble that of the normal heart. Vagal tone is also enhanced, so both heart rate and myocardial oxygen demand will decrease. Digoxin slows conduction velocity through the AV node, making it useful for atrial fibrillation. So the third mechanism is by neurohormonal inhibition. Low-dose digoxin inhibits sympathetic activation with minimal effects on contractility. This effect is the reason a lower serum drug concentration is targeted in heart failure with a reduced ejection fraction. So the adverse effects: anorexia, nausea, vomiting, blurred vision or yellowish vision may be initial indicators of toxicity. When Na plus K plus ATPase is markedly inhibited by digoxin, the resting membrane potential may increase, which makes the membrane more excitable, increasing the risk of arrhythmias. Then decreased levels of serum potassium, that is hypokalemia, predispose a patient to digoxin toxicity. Okay, so this is a very important point, that is hypokalemia predispose a patient to digoxin toxicity because digoxin normally competes with potassium for the same binding site on the Na plus K plus ATPase pump. And another important point is this digoxin is a substrate of P-glycoprotein and inhibitors of P-glycoprotein. Examples include clarithromycin, verapamil and amiodarone can significantly increase digoxin levels, necessitating a reduced dose of digoxin. So that it should be used with caution with other drugs that slow AV conduction such as beta blockers, verapamil and diltiazem. Thank you everyone for watching this video. If you find the contents of this video useful, please share this to your friends also, and let's see in the next video.